Thank you very much. Unfortunately, people are outside, but we will do our best. So this is at a controversial session where we talk about things that people have different opinions about. And my talk is about the second best arterial graft, Radial versus RIMA. I have nothing to disclose. As you guys know, that multi-arterial grafting is better than single arterial grafts, and these are the most important trials that discussed this issue, ART, coronary, and then meta-analysis, an STS database, and the relative risk is in favor of multi-arterial grafting. And this is a deeper look at the STS database, looking at 1 million patients with a survival advantage in favor of multi-arterial grafting. And this is another study that published 2014 in the Journal of Thoracic and Cardiovascular Surgery, looking at 983 angiograms with the patency in favor of arterial grafts in general, better than saphenous veins. So one of the landmark trials is ART trial, which is a randomized control trial that showed no difference at 10 years between single versus bilateral ITA. The MACE has showed no difference, and the mortality is no different between the two groups. And the main reasons for this is the radial artery that was in probably around 22% of the patients with single IMA, and there was a 14% crossover from the bilateral artery to the single ITA group. And a subgroup analysis by David Taggart in the circulation between the radial artery and saphenous vein showed that the incidence of MACE was higher in the saphenous vein rather than radial artery, so radial artery is better. But the issues with the cell wound infection and complications always higher in the patients with bilateral ITA, 3.5 versus 1.9, which is significantly different. And looking deeper into the specific trials, this is a RABCO trial you guys are familiar with. This is the first randomized trial to show that the radial artery is superior to saphenous vein and RIMA as a conduit of choice to second most important territory. So the MACE is significantly in favor of radial artery versus the saphenous vein, and in favor of radial artery versus the bilateral ITA. And this is another study published by Dr. Gadiano in 2020. So this is a meta-analysis. And they did put all the main studies in this: ART trial, RABCO trial, coronary trial, and PREVENT-4. And you can see the black line here representing the RIMA plus radial, which is basically significantly better in terms of all-cause mortality in favor of RIMA and radial rather than bilateral ITA. And this is the most recent guidelines, and in this guidelines, the American Heart Association, we had some issues with these guidelines as surgeons for the stable coronary disease, and some with the radial as well. But this is the radial arteries now is class 1 indication to do it with the level of evidence with all these trials that came BR. So this is also STS database, the number of patients, more than 1.5 million people. And you can see there is an operative mortality slightly different in favor of radial artery at the arm of multi-arterial grafting rather than the bilateral RTA versus the single grafting. But the deep sternal wound infection is higher for the bilateral RTA, which is evident in other studies as well. At this study as well, the graft failure always associated with low survival in a very high number of patients. And looking at the patency per graft, we all know LITA has excellent patency, and this is an angiogram that were done at 1 year. And if you go down, when you move from the lima to LID, it goes down, circumflex, it goes down, and RITA, unfortunately, when it's used to the left system, especially the lateral wall, the patency goes down. But to the LID, still okay, but not as good as the lima to LID. And this is the radial artery. It's consistent when you put it at the LID, at the left system, but not good at the right. That's why you have to have a significantly more than 90% to put it in the right system. The savinous vein, it's consistent wherever you put the vein. It's about like 70+% in all territories. There are technical considerations for the RITA grafting if it's in situ. It's not always long enough to reach to the targets that you want to reach. It did result in tension. It only reaches proximal targets, especially when crossing through the transverse sinus. If you have a high OM or ramus intermedius, otherwise it doesn't reach. Distal portion prone to spasm due to muscularity, and if you have to go back for any operation in the future, there is a significant risk of sacrificing the RIMA, which is going to a very important territory. To put a free RITA to any vessel, then you have to put it to the if you put it to the aorta coronary, then it becomes difficult because the aorta is thick and the RITA is thin, fragile, and small. So there are some technical issues associated with that. If it's a composite graft, normally there are some issues with the competitive flow because both distal ends dependent on the IMA proximal. If you have an issue with the anastomosis, you sacrifice both grafts. And the long-term patency of individual segments of different internal thoracic artery configuration using a Y graft, UCC, 1 and 3, this is the lima itself. The prevalence of occlusion is low, that's a one vessel. But if you put another vessel on top of the lima, then that's number 4 and 5, the patency goes down. So the occlusion is high. So the radial artery, when not to use it, if we have a target vessel less than 70%, normally it has to be very significant on the left system, more than 70%, and it has to be significant on the right system, more than 90%. People with chronic kidney disease or dialysis or future dialysis, they need that for fistula. Patients who doesn't have good ulnar test or ultrasound that proves that there is an ulnar artery compensation, a patient who had calcified radial artery with ultrasound or recent catheterization. So the most important trial that we're going to hear about probably in the next 1 to 2 years, which is the ROMA trial, which is unblinded RCT multi-center, comparing about 4,400 patients, comparing the multi-arterial grafting lima and RIMA and Radial. So comparing lima to LAD, and the second can do either Radial or RIMA to the lateral wall, and this is going to give us a detailed and better answers to the questions that people have. And then the second group going to be limato, LAD, and vein to the wrist. Primary outcome: death, stroke, MI, and repeat, which is classic. So probably we're going to hear about this in the next 1 to 2 years. In conclusion, multi-arterial grafting is better than single. Radial artery more versatile, and it's the best can do, in my opinion, when used for free aortic coronary anastomosis. RITA, strictly used as a composite graft compared to radial, is the next thing to study, and we're going to have answers for this in the future. Meticulous patient planning is very critical, very important to choose the right target and the right conduit after examining the radial properly and to put it where it deserves. And we have to outweigh the risks and benefits for each case, and the results could change in the future with the ROMA trial and STS database. Thank you very much.